Good afternoon, everybody. This is Corey Hill at the Partnership for People with Disabilities at Virginia Commonwealth University. I'd like to welcome you all to our June Talks on Tuesday. We are delighted to have Mandy Tribe joining us to present More Than Just a Bump on the Noggin, Traumatic Brain Injury in the Young Child. Mandy, thank you for joining us, and I'm going to turn it over to you.
Thank you, Corey. Thank you very much. Good afternoon, everyone, and hopefully the next hour is going to be informative and enjoyable at some point. Let me just give you a quick overview of my own experience. I've actually been a special education teacher for over 30 years. I did obtain my undergraduate degree at the University of Birmingham. That would be England, not Alabama, and have taught on both sides of the pond, mostly over here in Virginia in Norfolk Public Schools. For the past 9 years, I have been an educational consultant in the hospital school program at Children's Hospital of the King's Daughters in Norfolk. I work in various outpatient clinics, some of which have children with, we serve children with brain injuries, those in oncology and rehab, and sometimes in bleeding disorders. So after working with some of these kiddos for a while, I jumped at the opportunity to be able to work on my master's degree at George Washington University, and that actually is special education and transition with a concentration in brain injury. So that's basically how I got to where I am today, working with a lot of kiddos who have a brain injury. So our objectives for today, we are going to see an overview of the brain, the definition of brain injury and the different types of brain injury, the mechanisms and incidents of brain injury, signs to look for, particularly in the young child, as well as how you as early interventionists can actually help support children with a brain injury now and later in their school career. So we're going to start off with a question, and I'm going to want you to use your pointer tool to make a selection. Is a concussion a brain injury? Yes or no? So please go ahead and make your choices. Okay. Obviously, people are very well informed about brain injury right now. Yes, a brain injury is actually considered a mild traumatic, a concussion is actually a mild traumatic brain injury. A traumatic brain injury is actually considered a continuum, and a concussion is on the mild end of that continuum, and it actually goes from mild up through moderate to severe. We're trying to get away from what people have liked to refer to as, you know, just a ding. Oh, he can keep playing football, he only took a ding to the head. Or with little ones, he only bumped his noggin, so it's okay, it's nothing to worry about. And we've been finding that that is not necessarily the case. And a concussion or a mild brain injury does actually need to be taken seriously. We don't want to just blow this off and send that kid right back into a game or totally ignore what's going on with a concussion or a mild brain injury. Basically, a mild traumatic brain injury can actually occur with or without a loss of consciousness. It actually may be very difficult to diagnose and doesn't always show up on an MRI or a CT. If it's not treated and accommodations are not put in place, it can actually result in dire consequences. For older kiddos, rest is recommended. It is also recommended that they have nothing to do with their phone, computers, TV, any of those kinds of devices. And it is also recommended that they stay out of school for a certain amount of time and do not participate in sports. With little ones, they need to be more closely monitored and really pay really close attention to them, because obviously they can't express what's going on as well as the older kiddos do. And so, as it says here on this slide, if precautions are not taken when someone sustains a mild traumatic brain injury, that their risk for a second injury is actually 3 times greater than the general public. And this is because that first injury can impact decision-making, impulsivity, and motor skills, and these all, if they are not taken care of, could result in that second injury. And then the risk for a third is actually 8 times greater. So it is very important that it's taken seriously, accommodations are taken into consideration whenever this happens. Now, traumatic brain injury as far as the schools are concerned, and I know you guys have the little ones, but they are going to get older, and it's possible that some of them may, if they've sustained a brain injury, may need services later on. So basically, how a child qualifies for special education later in life is that it has to be caused by an external physical force. It could be an open or closed injury, and obviously has to result in total or partial functional disability, psychosocial impairments, or both, and it has to obviously adversely affect the child's educational performance. Now, a traumatic brain injury is actually part of what is considered an acquired brain injury. That is more of an umbrella term for also any injury that occurs internally, such as a stroke, a brain tumor, anoxia, and so on, as opposed to the traumatic brain injury, which is the result of the external physical force. I'm actually going to go into a little more depth in a few more slides as to what the different acquired brain injuries are. So, what is this extraordinary thing called the brain? Actually, an adult human brain weighs about 3 pounds, whereas a newborn human only has a brain weighing about 12 to 14 ounces. There was an article in August 2014, which is actually listed on your resource list. It's called Baby's Amazing Brain Growth Revealed, and it was in the magazine Live Science. And in this article, researchers scanned the brains of 87 healthy newborn babies 211 times, starting when the babies were only 2 days old. They found that the newborn brain grows extraordinarily fast right after birth, but slows down to a growth rate of 0.4% per day by the end of 3 months. Overall, infants' brains grew by 64% in the first 90 days, according to the study. The average brain size was 20 cubic inches at birth and 34 cubic inches at 90 days. In other words, the brains of newborns grew from about 33% of the average adult brain size to 55% of it in 3 months. Quite an incredible feat. So, we know how a brain grows, but what happens to it during an injury? So you have to have an idea of what the brain is like inside the skull. It's not stationary. It's kind of like Jell-O in a bowl. That's the kind of substance it is, and that's how it kind of will move around if the brain is moved or very quickly or undergoes some kind of trauma. So when the brain does sustain some kind of trauma, the cells basically get shaken up, kind of like the particles in a snow globe. And the brain needs time for all of those cells to basically settle back down, just like the little glitter or the bits of snow in a snow globe do. And that is why it is always recommended that following any kind of trauma to the brain, whether it's a mild injury / concussion or anything more severe, that rest is the first thing that happens. So also when an injury occurs, the brain is bouncing around inside the skull. And inside the skull, it's not a nice, smooth piece of bone. It's actually very sharp and bony. And so when the brain starts bouncing around, it's going to bump up against those very sharp, bumpy areas. And then the outside of the brain is going to be torn and result in injury in that way, as well as something called shearing on the inside. And that is when the axons in the brain stretch out and become damaged. Another concern during a brain injury is the possible need for a craniotomy when swelling occurs. And what happens with a craniotomy is part of the skull is actually removed to allow the brain to expand. And then once that swelling goes down, that part of the skull is put back on the skull. I'm just looking at Corey's comment there, jello in a bowl. Yes, well, that's a pretty good analogy, actually. All right, so there are two main types of injuries that can occur to the brain. You have a focal injury and you can have a diffuse injury. The diffuse injury generally occurs when the brain has bounced around inside the skull, as I described in the previous slide. And when that happens, multiple areas of the brain can actually be damaged. A focal injury is when just one area of the brain is damaged, for instance, in a gunshot, or if something other than the bullet penetrates the brain. However, it is good to bear in mind that the brain does work as an integrated functional unit. So any damage done to one area of the brain can also impact other areas. Although I do recall one student I worked with who had actually been shot in the brain. And it was actually, this is not labeled, but it's called the motor cortex right here, and that's where he received the damage to his brain. I hope everyone can see my pointer right now, where I'm showing where the motor cortex is in the brain. And after surgery and therapy, he actually only ended up having some motor issues, which was quite incredible. It is very important to understand what each part of the brain does if you are working with a child who has sustained a brain injury. So I'm just going to go through the different areas right now, and we're going to start with here with the cerebellum. And the brainstem is right here. The brainstem is the area that oversees and controls the vital bodily functions such as respiration, heart rate, and blood pressure. Here we have the occipital lobe, and that controls vision. The parietal lobe right here is in charge of perception and making sense of the world, as well as arithmetic and spelling. The frontal lobe is pretty important because that is in charge of all the executive functions, thinking, planning, organizing, problem solving, as well as emotions and behavioral control and personality. Like I said a minute ago, here is the motor cortex, which is not actually labeled here. Next, near to that is actually the sensory cortex, which is in charge of sensations. So we will go on to now another question. Which do you think is the most common cause of brain injury in children aged 0 to 4? Now if you can go up to your lowercase a and go ahead and vote to see which of these you think is the most common cause of brain injury. Is it motor vehicle traffic? Is it struck by or against an object? Is it assault or is it falls? So.
And again, if people are looking for where they vote, it's right under your name in the Blackboard tools. There are four boxes. Find the one with the lowercase a. Hit the little arrow in the corner and you'll see a drop down and you can make your choice.
Okay, have we had everyone voting?
I think it looks pretty good, Mandy. Jeannie, if you could pull the results. There you go.
There we are. Thank you. Okay. All right, so we have quite a few people who have not voted yet, but then 37% think it's falls, 5% assault, 1 struck by or against an object, and A, motor vehicle traffic. Actually, it is falls, so well done to those of you who thought that was what the case was. And 73% of injuries, brain injuries, are caused by falls. Excuse me. So why do we think that's the case? Well, with our little ones, obviously their motor skills are still developing. They're curious, and they've got those big heads they're still basically trying to grow into. So all of those contribute to falls being the significant cause of brain injury in small children. So how can we help prevent something like this happening? Obviously, making sure that play is a safe activity for them. Falls on the playground are a common cause of injury, so we need to make sure that the surfaces and the playground equipment are safe, soft, and well maintained, using such things as wood chips or sand and not dirt or grass. We want to encourage our parents to make their homes safer, using home safety devices such as guards on windows that are above ground level, using gates on stairs and other guardrails. And making sure that these devices prevent these little ones from taking a dangerous tumble. We want to keep sports safe as the children get a little bit older. Even things such as inline skating and learning to ride their bicycles and tricycles, making sure that they're wearing their helmets, knee pads and elbow pads, and wrist guards. And supervision. We really want to supervise our children at all times around any fall hazards, such as stairs and playground equipment, whether they're at home or at play. So then the next likely method of injury is being struck by or against, and that is for 50%. Abusive head trauma, which includes shaken baby syndrome, which I know is a concern for early interventionists, is a preventable and severe form of physical abuse that can result in an injury to the brain of an infant or a child. Abusive head trauma is most common in children under 5, with children under 1 year of age at most risk. As we all, I'm sure, know, it is caused by violent shaking or by being hit with a blunt object of some kind. The resulting injury can cause bleeding around the brain or inside the back layer of the eyes. Nearly all victims can suffer serious long-term health consequences such as vision problems, developmental delays, physical disabilities, and hearing loss. At least 1 of every 4 babies who experiences abusive head trauma, including shaken baby syndrome, dies from this form of child abuse. Research shows that it often happens when a parent or caregiver becomes angry or frustrated because of a child's crying. The caregiver then shakes the child and or hits or slams the child's head into something in an effort to stop the crying. It is a leading cause of physical abuse in children under the age of 5, as I just mentioned. And it accounts for approximately 1/3 of all child maltreatment deaths. So we obviously need to be making sure that our parents are educated in how to deal with inconsolable crying and a child that is upset, so that we can ensure that these numbers can be reduced in the future. And then we have motor vehicle traffic accidents, which accounts for 4%. Amazingly, every hour, nearly 150 children between the ages of 0 and 19 are treated in emergency departments for injuries sustained in motor vehicle crashes. More children aged 5 to 19 die from crash-related injuries than from any other type of injury. Motor vehicle injuries are a leading cause of death among children in the United States, but many of these can be prevented. Obviously, buckling children in age and size-appropriate car seats, booster seats, and seat belts reduces serious and fatal injuries by more than half. And so also encouraging our parents to not only use these restraints, but to use them properly is very important. I know in this area, the fire departments are available to make sure that the restraints are being used appropriately. And there's also a website on Parents Central called safercar.gov. Can also help with that and get people hooked up with where they can go to get the kind of support they need for that. Now, there is a particular type of injury that occurs in all the cases I've just mentioned, and this is called the coup-contrecoup injury. So what happens is, say we're in a car and here's a little kiddo in his car seat and the car stops suddenly. Well, his head keeps moving forward, and when it stops, the brain then bangs into the front of the skull. Then it will go back again. So this is the first coup or hit, and then coming back again is the contrecoup. So known, as it says up here, as the coup-contrecoup injury. So who can tell me which areas of the brain are going to be impacted in this kind of injury? And we're going to be using the chat box. Is that correct, Corey?
Yes, that's right. If you can look at the picture, that will help you, and then type your answer in chat. Thanks.
Yes, it looks like everybody's putting frontal lobe and occipital lobe. And Brandy here also made the point that overall the entire brain will be involved. Yes, that is correct, because of the it's also going to result in a diffuse injury that is impacting the entire brain. Now, here we go. So the frontal lobe right here is going to be impacted, and that's very important for future functioning that I will be talking about a little bit later, because as I mentioned earlier, all of the executive functioning goes on in this particular area. And then in the back here is the occipital lobe, and basically if you've ever hit the back of your head and seen stars, kind of like in the little cartoons when one of the characters bangs their head, they see stars. Well, that's because it's your occipital lobe that's being received the impact at that time. So very good, everyone. Thank you. Other types of injuries, acquired brain injuries, include brain tumors. Many kinds of different brain tumors can impact a child, and again, depending on where in the brain it is how the child is going to be impacted, and how it also presents more often than not. We also have something called hypoxia or anoxia. Hypoxia, as I'm sure many people know, is a low level of oxygen. Anoxia is a complete lack of oxygen that can occur during drowning, poisoning, suffocation, or even an asthma attack. I had one kiddo who sustained a severe asthma attack and ended up actually stopping breathing and sustaining pretty significant brain damage after the attack, and still to this day tends to have a lot of issues resulting from the anoxic event. Getting back to drownings, according to the CDC, drownings are the leading cause of injury death for young children ages 1 to 4. 3 children die every day as a result of drowning, and those who survive may have long-term disabilities, including an acquired brain injury. Strokes can occur in children. It's not just something that happens in the elderly. And they can occur for many different reasons, including side effects of sickle cell disease, injury to large arteries, and any child that has a heart condition could also be at risk for getting a blood clot, which then could result in a stroke. And then, like I said, here is an example of a child who's sustained hypoxia or anoxia. Then there is also infections of the brain, such as meningitis, encephalitis, and brain abscences, which occur from infections. And then there's cerebral palsy. I'm sure we've all worked over the years with children who have had CP. And it is actually considered an acquired brain injury. And CP is something that can occur before, during, or immediately after birth, while the infant's brain is under development, and it can affect a child's motor functioning and intellectual disabilities. And how it is affected is obviously very dependent on the nature of the brain injury, where the damage occurs, and how severe it is. Every case of cerebral palsy is unique to the individual, as we all know, and has to be taken care of as needed by the individual child. Okay, then we have something which is being studied more and more nowadays, and that is extreme neglect. There are actually academics from 5 British institutions, including Oxford University, who are currently planning to study the brains of troubled children in an attempt to prove that their wiring was affected by the abuse or neglect that they had suffered as toddlers. This example right here is an example of the brains of 2 3-year-old children compared by an MRI scan. On this side is the brain of a normal 3-year-old child, and this is the brain of a 3-year-old child who has been neglected. And this was a child who was adopted from a Romanian orphanage, who had minimal exposure to language, to touch, and any kind of social interaction. You notice that the child's brain overall is smaller and has enlarged ventricles right here. And the problem with this is that it can lead to a buildup of cerebral spinal fluid, and if not taken care of, could eventually cause swelling of the brain or hydrocephalus. So recognizing the signs of traumatic brain injury in the young child. The types of symptoms as well as the severity will vary according to how the brain damage occurred. Some of the symptoms will be immediately noticeable, while others may not surface until the infant shows signs of any kind of developmental delay. Sometimes bumps to the head can be significant enough to be concussions, but it can be difficult to recognize in young children. They may have the same symptoms as an older child, but not be able to express it in the same way. Obviously, they cannot express such symptoms as nausea or amnesia. It's really important for us as interventionists, as educators, and as parents and family to have a good understanding of the child's baseline behavior before any kind of damage has occurred. Once again, another patient that I have worked with a few years ago sustained a brain injury, and I remember being actually at an IEP meeting, and certain behaviors were being discussed. And Mom mentioned, well, he had those kinds of behaviors prior to the brain injury. This child already had a pre-existing condition of autism. So you really need to have a good understanding what was the child like before the brain injury to be able to compare to their behaviors and functioning afterwards. Really, you can't blame everything on the brain injury, and it's important to know, like I said, what were they like prior. So basically, a TBI can affect some or all areas of functioning in a child, so such as in cognition. Obviously, any delays in development are going to be areas of concern, as I mentioned earlier. Sometimes the brain damage cannot be detected until the infant is showing those delays in development. And we know that babies don't all hit the same developmental milestones at the same time. And only a physician is going to be able to ascertain if an infant's developmental delays are a result of brain damage. So intellectually, they can be impacted, their memory, their attention, verbal and nonverbal communication. Executive function, not quite so much in the small children, because that's not developed until later on. Then we have behavior. Any kind of abnormal temperament is going to be a red flag. We know it's obviously normal and expected that infants are going to cry. However, any excessive crying, high-pitched wails, combined with other abnormal behavior, such as refusing any kind of nourishment, being extremely fussy, those are all red flags for the possibility of some kind of brain damage. Also, the inability to be consoled, vomiting, restlessness, being more impulsive than they may be used to be, changing in sleep patterns, low or lack of motivation, and being extremely lethargic. Then we have the physical and sensory abilities. Once again, fatigue and sleep problems come under this area, headaches, seizures, motor coordination. If you suspect there might be any hearing or vision issues, some sensory sensitivity, again, articulation. And obviously, if the child just looks different, if their head is too small or too big, or just deformed in any way, or it looks like they're having trouble focusing, these are also indicators of possible brain damage. Social emotional, again, things like, does the child appear to be depressed or anxious? Excuse me. Are they having extreme mood changes, anger, irritability? Obviously, you know, we'll see changes in emotional states in our little ones, but once again, anything that may be different from how they may have been acting prior to bumping their head, falling off their tricycle, or whatever. Also, if the child is having difficulty with social interactions, preferring not to play with their favorite caregiver or siblings or other children, extreme bossiness that they may not have seen before. And I know it sounds like it's very difficult to recognize the signs of a brain injury, and it really is, and not just in small children, but in the older kiddos also. So we have another question for you. Childhood, when childhood is considered basically from 0 up until about 24, Who is at most risk? So if you could go ahead and vote again, like you did in the previous slide, please, and let me know who you think is at most risk. Okay, W sitting. Not quite sure what that is, but okay.
Mandy, that actually was a comment from one of the pictures a couple of slides back that says
Alrighty.
just the way she was sitting was called W sitting, and I put a comment out to physical therapists, so we'll find.
And thank you for responding about the question about the dark spots. So yes, it looks like everybody is agreeing that age group A are the most at risk during childhood. Hence the need for us to be aware and know what to put in place to not only prevent but also be able to provide services for these kiddos. And those of you out there who are parents of boys, as I am, it's also interesting to know that males are 1.5 times more likely to sustain a brain injury than girls. So obviously because they maybe tend to do a little more risk-taking, they're a little more, go at life a little more hard and just enjoy playing a little more actively than the girls do. Wouldn't the older child's brain be less resilient? Lisa is asking that. We're going to get to that in a minute, the difference between a young child's brain and an older child's brain. So we're going to discuss that in just a couple of slides. Piggybacking onto the need for being aware of children in the 0 to 4 age group, basically eligibility for early intervention. There are many conditions, syndromes, and injuries that do relate to brain injury that may qualify a child for early intervention services. Some examples include brain spinal cord trauma with abnormal exam at discharge, and a grade 3, grade 4 intraventricular hemorrhage or infantile stroke are just 2 examples of those who could be found eligible for early intervention, as well as obviously the determination overall by the eligibility committee while meeting the eligibility criteria. So now we're going to get into the difference between a 3-year-old and a 17-year-old. Who is more likely to make the better recovery here? So if you could once again put your pointers on who you think is going to make a better recovery. Is it a little 3-year-old here or a 17-year-old? Okay. It looks like we have most people thinking that it's the 3-year-old. Obviously, because a little thing called neuroplasticity. Okay, we have a couple more people on the 17-year-old. So, it's actually the 17-year-old. And why is that? Well, when someone sustains a brain injury, in the early months, weeks, months, basically leading up to a year and a half, that's when significant relearning of information and skills occur. So if that's the case, think about how much the 17-year-old has learned as compared to the 3-year-old. Old knowledge is learned first and is learned quickly. So this 17-year-old has much more cognitive reserve to call on. So that's why he's going to make a better recovery than the 3-year-old. For very young children, the impact of the injury may not be apparent until later. The child may return to baseline after treatment because their developmental stage is not demanding a lot of sophisticated functioning. This is called delayed onset of symptoms. Particularly in the frontal lobe areas, I always like to think that we are the frontal lobes for our young children. We are making decisions for them. We are telling them where to sit in the classroom, when to open their lunch, or how to open their lunch, or provide help for them. In kindergarten, where they should put their book bag, and so on. So we're not going to notice until the child is being asked to use those executive functioning skills that there may be a problem. Once we start demanding more organization, more impulse control, more initiative, is when we start to see those concerns. And that may not start until the child starts school, or even transitions to middle or high school, when those demands get higher and higher. In my experience, both through the hospital and through other trainings that I help with, parents of young children who have sustained a brain injury are being taught to point out to professionals that their child is growing into their brain injury, particularly as they age. Another example of a kiddo I worked with was a young lady who was a shaken baby when she was about 2 years old, and recovered pretty well, and was developing, got through elementary school okay, but once she started getting to middle and high school, that's when significant problems were being seen in the school settings. And it's very difficult to try to explain to school personnel why this is happening when they want to talk about, well, they're being a typical teenager, or she must have ADHD, or she must have psych problems, and that kind of thing. So recovery. It's going to be unique to each child. It can maybe be 2 to 3 weeks for a child who has sustained a mild brain injury, requiring rest and no stimulating activities, as I had mentioned earlier, or it could take years for a severe brain injury that involves complex surgery, weeks or months in a coma, and weeks or months of rehab therapy and ongoing special education services, resulting in possibly lifelong care. So it is a continuum. If you remember one of those earlier slides, I showed that continuum of brain injury that goes from the mild all the way to the moderate to severe. I know you guys are early interventionists and you do concentrate on the 0 to 4 population, but you can help with ensuring that appropriate identification, programming, and services are in place by educating parents about brain injury and the possible long-term effects, encouraging them to take their child to a doctor even if they just seem to have got that bump to the noggin when they fell off their tricycle, encouraging them to keep documentation in case their child does develop learning difficulties later in their school career. Social workers who sit on eligibility committees are now asking about any history of brain injuries. They don't say to the parent, did your child sustain a brain injury? They will ask things like, did they ever fall off their bicycle or fall from the jungle gym, hit their head? Were they ever seen by a doctor? Did they ever go to an emergency room? And so on. Because traumatic brain injuries are often mistaken for other disabilities when there is no history or documentation. And that's why we're seeing in the schools that there is this it's considered a low incidence disability. It's significantly under-identified. Because if we're seeing 1 million children sustaining brain injuries and TBI is less than a 1% of our special ed services in Virginia, then there's a big disconnect here. And so we want to make sure that we don't want to get people going crazy thinking that every child who's bumped their head has a brain injury, but we want the parents to have that knowledge that if, when their kiddo gets to middle or high school, that they're having significant learning problems, that it is at least considered. And having that kind of documentation is definitely going to help the schools provide the appropriate programming and services. So here's a quote from a really good site that is listed on your resources, brainline.org. John says, brain injury is like thinking with speed bumps. And basically, recovering from and living with a brain injury is not a smooth and straight road for anyone. It can be bumpy, it can be twisty, unexpected hazards can occur along the way. Generally, after that first year of rapid recovery that I mentioned earlier, there does tend to be a period of cognitive stall, no matter the age of the person who sustained the brain injury. And after that cognitive stall, progress can be very up and down. It can often result in frustration, not only for the child, but for the family and school staff or those who are taking care of the child. And so I'd like you to just bear some of these things in mind as I finish up right now. Not every brain injury is the same. Not every person brings the same brain to their brain injury or to how they sustain it. It can be confusing to those who work with students with brain injury because it can manifest differently from moment to moment, resulting in the need for ongoing evaluation and changes in teaching, especially when the child hits one of those low points. And many children, if they don't have an open or obvious injury, are going to look normal. That's why it's often considered or referred to as an invisible injury. And that's why it can be so difficult for people to understand it and to be able to provide appropriate services. And once again, understanding the child's pre-morbid condition, what was their baseline prior to sustaining the brain injury, especially with those young kiddos that all of you guys are working with who don't have the communication skills to tell us how they feel and what they're going through. So, that is it. Does anyone have any other questions?
Hi, everybody. This is Corey. And Mandy, I just want to hit a couple things that popped up in chat and make sure. Chesapeake had asked about the black spots, and then they typed ventricles. So, Chesapeake, if you can just type in if you got your question answered or if you need more information. And then Lisa had asked a question about the resilience, and Mandy mentioned that she was going to cover that later. So Lisa, if you could just let us know if you got your question answered. Thank you, Chesapeake. It looks like their question was answered. And then Mandy, I just wanted to let you know that T. Boswell commented that he or she was surprised that 5 years and up do not have more issues, since this is when they're doing more motorically challenging things. So kudos to parents who use protection for headgear.
Absolutely. Absolutely.
Let's see. Bev is asking on page 11, is the skull size the same? Just the brain is smaller. I think, is that the one about neglect?
Yes.
Is that the picture?
Yes, I just pulled up the picture for you. Yeah, the overall size of the child is smaller.
Okay. Let's see. Infant Toddler Connection of Southwest said, so often children bang their heads when tantruming. Parents report being told not to worry about it. Could a child get themselves a TBI in this way?
Well, I mean, you know, if they're banging their heads on something really hard and it's being consistent, then, you know, it's something to bear in mind. So parents are being told not to worry about their children banging their heads when tantruming. Maybe they should be encouraged to try and, maybe put a pillow between the child's head and whatever it is they're banging their head against, just to,
exactly.
Make sure. With a smaller brain, you can neglect.
Yeah.
Okay. I think that's something that they're probably trying to research right now. I mentioned that there is a research going on about this. I don't know. To be honest, I don't know the answer to that. One would like to think that that's the case, and someone said yes in response to. Are you responding to that question, Bev?
I think actually Bev was responding to, we were on the right slide and the right.
Okay.
The right slide for her. So sounds like that one's something we probably need to get more information on. There is one, Mandy, is there any research on whether children with TBI are more prone to dementia or Alzheimer's later in life?
I have not seen any, and that's possibly because we've only just really started getting a better handle on what's going on with children with TBI right now. So I'm sure that research will come along later. I do know that with the NFL footballers who it's been shown that they have damage to the white matter in their brain, that they are more prone to dementia and Alzheimer's. So, it would not be terribly surprising if that is found to be the case.
Yeah, I think if those of you who are interested in this kind of thing, that movie Concussion that came out, even though it was Hollywoodized, it certainly was a remarkable study by the University of Virginia, and a neuropsychologist collaborated with football players, so and then worked with the NFL. So that might be something for you all to check out.
Right.
Mandy, Sarah says, we have a child who consistently slams his head against things when frustrated multiple times per day. As a facility, do we need to insist that he wears a helmet or cannot be in the school camp environment?
Wow. Obviously, that's going to be your facility's individual decision on how you want to do that. But thank you. Yes, Dana, good question for the pediatrician. If he's slamming his head multiple times a day, I would say that would be something to try and encourage in that child's case. I remember in the past when I was in the classroom, I had kiddos who had seizures, one in particular who would just drop like a stone, and he always wore a helmet to protect his head. Okay, I'm not quite sure what Bev's question is.
I believe Bev might be responding to the question about the child who bangs, that has the child had a hearing screening or is a school psychologist involved. So I think Bev is just offering other things to definitely consider for that child. Yes, thank you, Bev. I see a couple people are still typing, Mandy, so we're going to wait just a minute. Sarah says, yes, thank you for the answer to your question. Definitely a bit complicated situation.
Very much so, yes. As someone who I get to go out to the schools when we have had patients discharged here with brain injuries, it can get very complicated. The young man who had the asthma attack when he went through eligibility came out with an LD profile. Well, as I had said, the children's abilities and functioning changed so quickly over time following the brain injury. I quickly diverted the school from trying to find that child as child with a learning disability, because I said probably in 6 months to a year, if you retested, he's going to have a completely different profile. So yes, it's very complicated.
Okay, I am going to ask you all one more time if you have any other questions to please post those in chat. While you are doing so, we wanted to let you know that we have a new page that has been created on the Virginia Early Intervention Professional Development site. It's a page dedicated specifically to traumatic brain injury. This topic was actually a topic suggested by early interventionists in Virginia. So there are lots of good resources on that page, and Mandy's archived webinar from today and the resource list, and you can see in chat that Jeannie has posted that new web page. Andy, I'm not seeing any more people typing, so I think that we are probably very good. I want to thank you all for your time, and Mandy most especially for your expertise on this interesting topic. I wanted to remind you all that Talks on Tuesday takes a break for July and August. So if I could sing, I would sing See You in September. We are excited about some of the topics we have coming up for the fall and hope to see you all for the September one. So thank you, everybody, and have a good rest of your afternoon.